Good afternoon. First of all, we want to thank the Scientific Committee for accepting this experience as a facilitated session.
We are delighted being here at HPSN World.
Let us introduce ourselves. I'm Eduardo Alcaraz. I'm a medical doctor. I'm a pathologist.
I am Fuensanta Caballero. I'm an intensive care unit registered nurse. We come from Murcia, in the southeast of Spain, by the Mediterranean Sea.
We would like to show you our experience in medical simulation in our institution in fine needle aspiration cytology using phantoms.
We have no conflict of interest to disclose.
We are going to split this lecture in 3 sections. What is FNA? What is our simulation about? And how are we doing it? When we started 4 years ago, receiving students from medical school at our pathology department, we realized there was nothing developed yet to acquire practical and real knowledge about our specialty. They was just standing there, staring at us and following us during the whole day. That was just the same old stuff. Therefore, we didn't want them to waste their time and to get bored. It was when we thought, it's time to make a change. It's time to be part of it and teach real skills and make the process beneficial for them and for the patients. What is FNA about? What are we talking about? Does anybody know what is an FNA? Fine needle aspiration is a technique which is widely used in the daily routine of any hospital or clinic. This is an extremely useful, cost-effective and minimally invasive diagnostic procedure to characterize lesions and to diagnose patients. The lesions can be palpable or deeper non-palpable. In the latter case, the FNA is performed guided by imaging techniques like ultrasounds or CT scans. Using a sterile technique, we introduce a small needle into the patient's lesion and move it back and forth until obtaining cells. After a few seconds, we withdraw the system and place the material on glass slides. So we need just a few seconds to obtain a good sample of the patient, minimizing the suffering. So we expel the material on glass slides and we spread it to prepare the smears. We dip these glass slides into alcohol solutions to preserve and fix them, or even let them get dry depending the staining we want. After that, a technician helps us staining these smears with the different dyes, such as hematoxylin, eosin, Gemsa or Dead Quick. The technician dips the glass slides into the different liquids and finishes with covering them in a few minutes. This procedure allows us to color the cells of the patient. Cells have no color. We cannot see cells without staining them, so we cannot diagnose without staining them. Then we can assess the quality of the sample and even provide an approach to the diagnostic of the lesion under the microscope. A pathologist is necessary to diagnose and is the one who makes an interpretation on what he sees. This is not an analysis made by the machine. This is not a blood test. The decision and the report of the pathologist can radically change the life of a patient, using words like cancer or metastasis. In this case, for example, we've made the procedure on a lymph node in a patient, and we can see the background with red blood cells and lymphocytes, that is, a lymph node sample, but with additional atypical population of cells. Cells group into nest and with malignant features, such as hyperchromasia, increased nucleocytoplasmic ratio, and pleomorphism. So look at the red blood cells as a background, the tiny lymphocytes, and those malignant cells. We can then provide a diagnosis of a metastatic carcinoma in a lymph node with an unknown primary. With this diagnosis, the outcome of the patient changes. With this procedure, we diagnose the disease. We can obtain different diagnoses, including lymphoproliferative disorders, that is, lymphoma, breast tumors, inflammatory and infectious diseases like tuberculosis, metastatic disease, thyroid tumors, soft tissue tumors, among others. Pathologists are directly involved in 70% of medical decisions. And remember that cancer is diagnosed by pathologists. In addition, we can have information about the causes of the disease, about the etiology. For example, viral or bacterial, like human papillomavirus or tuberculosis. We can stage the cancer to help the oncologist with the treatment of the patient. Finally, we can obtain molecular information of the tumors for personalized treatments. Nowadays, there are drugs which work on a patient depending on the molecular profile of the tumor. How does it work? How do we perform FNA? For the procedure, the syringe and the needle are usually connected to this system, to a vacuum system, for example, a Cameco pistol or an Aspiración gun. We have to assemble them like this. And once the needle is inside the patient lesion and the vacuum is produced, an energetic movement of back and forth inside the lesion is essential to obtain a good sample. You can see here some material in the hub of the needle. If we do the procedure in a proper way, this is the amount of tissue we expect. If we don't do the procedure properly, it becomes a bloody and an inadequate sample. In that case, we will have to repeat the procedure, increasing the patient's suffering and the possible complications.
The size of the needles varies depending on the lesion or the operator's preferences. We tend to use the smallest gauge, that is around 25 gauge, that provides a satisfactory yield in the great majority of cases. Local anesthesia is hardly ever necessary, but some do employ a topical cream or lidocaine injection to minimize pain. Despite being a minimally invasive procedure, some complications have been documented apart from self-limited hematomas and local infections due to inadequate aseptic methodologies. For example, there have been described pneumothorax in FNA procedures on the chest, or airway obstructions when the procedure has been performed in the thyroid area. Another possible complication, but rarely described, is the metastatic seeding. We have here a breast carcinoma and if you spend a lot of time inside the lesion, it is possible to produce a track of tumor cells along the way. We are sure you all know this report by the United States Institute of Medicine from 1999 about medical errors. We all want to avoid mistakes and build a safer healthcare system, and that's why we are here at HPSN World.
This technique can be performed by any physician, mostly pathologists, surgeons, radiologists, endocrinologists, among others. But the most important thing is to be trained. What's the current situation? Does anybody knows how does it work in your institution? Well, in the few places where this technique is taught, this is done on fruits, believe it or not. Or what is worse, is performed directly on the patient for the first time. And that was my own experience. I didn't feel neither safe nor comfortable, and I was scared of it. I still remember the face of the patient looking at me. I'll never forget it. Result limitations and lack of standardization in teaching programs at medical school make teaching this technique difficult. The results, deficient training of students, and the consequences, patient safety risk.
Well, where do we go from here? We both work in a university hospital in Murcia, in the southeast of Spain. It is a medium-sized hospital with around 500 beds. Then, arising from the need, we developed and patented 2 Mannequins with different places to perform fine needle aspiration cytology. And we have applied for the international patent as well. They have several places where you can perform the procedure. The loads are compressible and you can feel the tumoral lesion by touching them. They allow the whole FNA process to be performed, which consists of palpation of the area, puncture, and aspiration into these different locations like neck, axillary, supraclavicular, or breast, among others. Then, you can proceed with the placement of the material on glass slides and do the smear preparation, like this. Furthermore, these Mannequins are reusable. We can change the content of the loads depending on clinical scenario, being more creamy in cases like tuberculosis, thicker like in breast cancer, or watery like in thyroid tumors. This is a pioneer experience that we started in the pathology department in our center 4 years ago. We are very pleased with the results and we want to show them to you. So, let's start the simulation.
This technique has been in practice for 4 academic years in the 3rd year at medical school. This picture shows how we set the stage. We have small groups of students from 4 to 8 and an instructor. We use digital images and our simulators. As you can see, the instructor is by the student side, stimulating them during the sessions. Look at the microscope in the upper part of the picture. We will talk about it later on. A simulated waiting room is presented to the students with several clinical scenarios. Currently, we have around 50 different clinical cases developed, including inflammatory, infectious, and neoplastic diseases. Clinical cases are presented with a picture, and a background history is reported by the facilitator. Here we have everything we need. We have syringe and needles, we have the Cameco pistol, gloves, alcohol solutions for an antiseptic technique, we have the glass slides, and of course we have the simulators. Each student individually is presented a simulated case. He has to face a patient. In this case, they must perform the fine needle aspiration procedure. First of all, students have to do the checklist. It includes making an anamnesis of the patient for a proper clinical correlation, explaining the procedure to the patient, and asking the patient to sign the informed consent form. After that, the student has to palpate the lesion, clean the area for the skin preparation with alcohol or chlorhexidine, assemble the system, the syringe, the vacuum pistol and the needle, needle the lesion and obtain a sample, and then they have to spill the material on glass slides and prepare the smears. At all times, students are supervised by the instructor, who guides them through the procedure, with the goal to make students understand what they are asked to do and encouraging them to do their best and to get the perfect sample from the patient. After performing the technique, each case is studied under the microscope to obtain a diagnosis. This is the only way to learn pathology. There's no other way to correlate the clinical background with the histologic features. But now things have changed, and we don't use the microscope anymore for teaching purposes in our institution. Nowadays, we use digitized images because students grown up in a digital world. They don't feel comfortable with microscopes, blinking their eyes, trying to focus. Each student has his own microscope with different slides, maybe some of them broken. They love digital stuff. So we can scroll through the image and zoom on it to see the disease, like this intestinal parasitosis, this giardiasis. We need a scanner of slides to digitize them. That is, taking lots of high-resolution pictures and combine them into a pyramidal image like Google Earth, so you can zoom in or zoom out. Here we are in the room with an interactive explanation of the different cases. We can correlate the cytology, that is individual cells in the smears, with the whole sample in the biopsy, which means the whole lesion for a better understanding of the disease. Currently, we have a set of 50 cases, which include a profile of the patient with a picture, a clinical background, and the digitized slides, both the smears and the biopsy. Do you have any experience with digital pathology? So now, this is a student perspective, the student's point of view. Here we have the waiting room with different clinical scenarios. For example, we have a 51-year-old male presenting with a parotid tumors for 6 months. We can see in the clinical picture a lump in the right parotid area. we explain things about the anamnesis. We have to ask the patient about the evolution, pain, or changes of the lesion, and explore and touch both sides in order to rule out diffuse and bilateral hyperplasias. We have also to ask the patient about anticoagulant therapy because the increasing risk of hematoma, and about an oncologic background to rule out metastatic disease. After the interview, we decide the best position for the patient to do the procedure, to be comfortable. Now we move to the simulators table. We have there everything we need: gloves, needles, syringe, slides, Cameco pistol, and the Mannequins. First of all, students must wash their hands with the antiseptic gel and to put the gloves on to avoid infections. As you can see, the instructor is by their side, answering any question they have. Students palpate the lesion to get an idea of the size and the depth of it in order to choose a different gauge for the needle. Then they take the syringe and have to assemble it to the Cameco pistol and the needle. This is an easy but an important step. They must know how to do it with no doubt facing the patient. Now they choose the size of the needle depending on the clinical background and the type of lesion. We have now to prepare the patient's skin. So the skin is wiped clean with an alcohol swab. Now the student is going to insert the needle within the lesion. And suction is applied by the syringe pulling the trigger of the Cameco pistol, like this. Now perhaps the most important part of the procedure is to move quickly back and forth inside the lesion. After a few seconds, they will see some material in the hub of the needle, and they must release the suction before the needle is withdrawn from the nodule, like this. Otherwise, the cells end up in the syringe rather than staying in the needle, and are dried and difficult to expel onto the slides. The student must ask for help to apply pressure over the site, to minimize bruising or to decrease the chance of hematoma formation. Now, to prepare the smears, the needle is removed from the syringe, and the syringe is filled with air. By reattaching the needle and pushing this air, a small drop of aspirated material is expelled onto the slides. It's difficult to see because it's white. They have now to learn the proper amount of pressure they have to perform between the slides. This is important because if it's too much, cells are destroyed, and if it's too soft, the sample has too many layers, gets blurred microscopically, and is difficult to diagnose. They have to introduce quickly the slides inside the alcoholic solutions before they get dry. Now the instructor explains then all the possibilities for the remaining material, such as culture, rinse the needle in different solutions for molecular test, or even cell block preparations. So now we have finished the FNA procedure, and we move on to the resolution of the case. So if we have 7 students, we have 7 procedures, and the rest can watch what the other is doing. In this moment, the instructor explains the microscopic results. They have to rule out benign or malignant diseases, or even metastatic disease. So knowing the microscope features in this particular case of a salivary gland lesion, here the student plays an interactive role, asking questions about what is on the screen, and the teacher is next to the student with no distance and more interaction than in conventional lesions. In this case, is a benign salivary gland tumor with a mixture of bland epithelial cells with pinky eosinophilic cytoplasm in a background of lymphocytes and red blood cells. There are groups of cells without atypia. They are benign. This is the second most common lesion of the parotid area. This is a worsening tumor. So we explain things about this entity, the microscopic features, differential diagnosis, and how to rule out malignant neoplasm. Now we tell the students a few words of the entity, in this case, worsening tumor. Things about the epidemiology, behavior, microscopic findings, differential diagnosis, treatment of the patient, and prognosis. And now, move on to the histologic picture to see the correlation of the cytology with the histology. This is the only way to learn this, watching both in a clinical context. It's easy to understand and in an homogeneous way, so all the students are watching the same and can ask anytime to the instructor. So we can show them the features in the biopsy to correlate with the smears of this worsening tumor.
Now, here comes the moment of the debriefing. It's time to be critical of everything we have done so far. After every case, a discussion is held on what has taken place in order to encourage the trainee to think about the experience, perceptions, decision-making, and clinical competencies. Students are invited to share their feelings on the problems they found, as well as their opinion about the procedure. Well, up to this point, we have shown you the complete procedure of the fine needle aspiration cytology with the simulators and with students.
How far we've come? Well, simulation has grown significantly at our institution. A total of 220 medical students in their third year from our university took part in this project. They learned the technique with a success rate on the first attempt of 97%. Additionally, 18 students from 14 other universities nationally and internationally performed the simulation. None of them had had the opportunity to do this practice in their places of origin. It is quite important. According to an anonymous survey we conducted, the practice was considered to be valuable with a score of 4.2 out of 5. So we thought there is no proper standardization of the practical aspects among different universities, and there's some inequality between students. We assess our debriefing methodology using the DASH, the Debriefing Assessment for Simulation in Healthcare questionnaire by Harvard. The students complete the long form. And here you have the results. For setting an engaging learning experience, for maintaining an engaging context for learning, for the debriefing organization, for provoking deep discussions, for assessing students' performances, for helping to improve or sustain good performance, with an overall score of 37 out of 42. That means we are in the right way. Our simulators have been shown around the world. They have been presented at the following conferences and places, including the United States and Canadian Academy of Pathology meeting in Seattle, the International Congress of Cytology in Yokohama, Japan, and me last summer in Barcelona, and this session at HPSN World in Florida, both oral or poster presentations. And in a few months we are going to stay in the Asia Pacific International Academy of Pathology in Indonesia, and we are going to send some presentations to CESAM in Paris. The British journal The Pathologist released 2 months ago a power list of the 40 most influencer pathologists of the year. This pioneer experience led us to be included in this list. As an active proponent of better medical education, including the use of new technologies like digital pathology and simulations. We firmly believe if FNA simulators were available, they could be included in the objective structured clinical examination evaluative formats. OSCEs, as you all know, have been implemented since 1975, but now they are widely spread around the world. One of the branches of the OSCEs are the patients or the simulators. We propose a 5 minutes in length station which includes these items for evaluation: anamnesis, palpation, antiseptic technique, FNA procedure, ask for help for compression, and smear preparation. We can check off each item when it has been complete during the station in the OSCE's exams. So what do you need if you want to implement this type of simulation in your hospital or university? Fundamentally, you would need simulators. And then, for further correlation and understanding of the diseases, you will need slides in a conventional way with microscopes or digitize.
As a final point, you need to know that these Mannequins and the whole teaching methodology are not in the market yet. They are handmade prototypes, carried out with enthusiasm and full of expectations, keeping in mind the benefits for the students and above all for the patient, who will face a trained physician. Our take-home messages are: we want to build a safer healthcare system, and that is the reason why we need simulators to practice on, avoiding procedures on the patient for the first time. We want to let you know that fine needle aspiration cytology is a daily procedure to diagnose patients, guiding us to provide the proper treatment for them, and we want the students to understand the value of that. We want trained physicians, so we have to work on it. And that's all. Thank you very much for your attention.